Okay, we're live. We're back. Hopefully, you had a great lunch. Anna did a great job with that recipe. And wow, it made me hungry. It made me want to go have lunch. The guy we have up next, he's been on the show a half a dozen times. He's from Canada, but don't hold that against him. And he is a Rush fan. So when you get to your questions at the end, if you have questions about the band Rush, he will answer those too. But this guy, he's always a crowd favorite when we have him on. He's a Ph.D. He's at Brigham Young University here in the good old U.S. of A. over in Utah. Folks, please put your hands together for Dr. Benjamin Bikman.
Wonderful. Thanks, Vinny. I appreciate the introduction, and indeed, I appreciate the invitation. Vinny, thanks again for reaching out. Andy, thanks for handling everything behind the scenes. Now, Vinny, you just pipe in. I'm going to transition now and start sharing my screen. If you see any problems with this, I'll just expect you to pipe in and tell me. All right. In fact, Vinny, can you just confirm from really quickly? Do you guys all see what you think? What I think you're seeing? You're seeing my talk now.
Yes, if you can hear me, Ben. Yes, I can
Yep.
see your screen.
Okay, beauty. All right, yeah. Thanks again for the introduction and the invitation. It's always a pleasure to talk to Vinny, and be a part of whatever he's putting together. You guys, I want to take this 40 minutes or so that I have allotted to just share with you my view as a scientist on health and wellness, and make this effort to bring much of our understanding of chronic disease into one sort of common soil hypothesis. So, why is it that we get sick? Now, just by way of disclosures, it is not every academic that is fortunate enough to do something on the side. I am fortunate. So, in fact, help me out. Buy my book, for heaven's sakes. But here's my disclosures. Why we get sick, some of what I'm covering today, although, of course, in much more detail in the book. And then with a couple of my brothers, we started a low-carb shake. And you can find more by looking up health code and at gethealth.com. So those are the disclosures. I'll make royalties from the sales of the book, and then someday make money from the shake. Now, to put all of this in context and to help you appreciate the relevance of metabolic health, let's just look at how bad it is. And this was a study published at the end of last year where they found that as I shared with you here, this is one of the direct quotes from this published manuscript, that metabolic health in the U.S. adults was alarmingly low. And this was happening even in people who didn't look like they were suffering from poor metabolic health. In fact, the actual numbers were that 88% of us, of U.S. adults, were considered metabolically unhealthy. And they based this on this constellation of 5 problems. That's how they defined metabolic health. So only 12% of U.S. adults had an acceptable waist circumference, blood pressure, blood glucose, and then blood lipids as measured by triglycerides and HDL cholesterol. In fact, you'll note that they did not include LDL cholesterol here, just because that varies so widely across healthy and sick people that it's not a great indicator of anything. So as we look at these markers of metabolic health, of course, the absence of these, or someone getting a so-called failing grade, that is, well, poor metabolic health. And in fact, these 5 represent the foundation of the metabolic syndrome. Let me just take a brief tangent that I wouldn't have mentioned, of course, just a few months ago. Studies, and please, throughout this lecture, you'll notice in the bottom of some of these screens, I have a little letter, a PMID, and then some identifying number. This is the citation, the scientific manuscript that I am citing when I'm sharing these kinds of things, just so that you don't think that I am bombarding you with my opinion. No, no. In fact, these are data, and so you can't just agree with them or disagree with them. If you find them troubling, of course, no one at this meeting will. If your friends find these kinds of things troubling, then you tell them to find the data to refute what you're telling them, because you're not sharing their opinion, and you can't disagree with data. You just refute it with other data. All right. So this study, based on data coming from New York, published in a very prestigious medical journal in the U.S., found that almost all patients with COVID-19 infections that presented to the hospital, so whose infection was bad enough that they actually were admitted, 94% of them had a pre-existing condition, one, and 88% of them had two or more pre-existing conditions. And here are the pre-existing conditions in order of most common. Obesity was pre-existing condition number 1. Hypertension was pre-existing condition number 2, and diabetes was number 3. And these are the crux of the metabolic syndrome. So it is the absence of these things that creates the metabolic syndrome. Now, once upon a time, the metabolic syndrome was called the insulin resistance syndrome. And that is, in fact, a more accurate term. It's not as provocative or compelling. Using the word metabolic, of course, just has such a wonderful ring to it. But the insulin resistance syndrome is more accurate simply because all of these problems are in some way derivative or stemming from insulin resistance. And the problem is so much more substantial than most people think. Here are the big 5, if you will. Body fat is intimately related to insulin resistance, and I'll talk about that in more detail in just a few minutes. Type 2 diabetes is entirely based on a foundation of insulin resistance. It is extremely rare to have any instance of heart disease without there being insulin resistance that has in fact preceded it. The most common cancers are exacerbated by insulin resistance, namely breast and prostate cancers. And then fatty liver disease, once again, that is a disorder, the most common liver disorder that stems from insulin resistance. And these might not be too surprising in a way, but there are others that might be surprising, like infertility. The polycystic ovarian syndrome is the most common form of infertility in women. And that is entirely a disease of insulin. Erectile dysfunction in men, in fact, there's a manuscript that says erectile dysfunction may be the earliest sign of insulin resistance in men due to what insulin does to blood vessels. And then there are more disorders, musculoskeletal and neurological or vascular with regards to stroke. So insulin resistance matters. And in fact, some of you listening might have it, or certainly your loved ones might have it. Here's just a little quiz. Let's pretend I'm your professor for a moment. High blood pressure, is that a concern? High triglycerides, do you have a family history of diabetes or of those infertility markers that I just mentioned, or fatty liver disease? And then the last one may be surprising. Do you have skin tags, teeny little bumps that elevate up from the skin, like almost little stalks of skin? And it typically happens at skin folds, like around the neck or at the armpits or groin. At those same spots, you could have these dark sections of skin, dark and kind of rough. Those are also very prominent and relevant signs of insulin resistance. So if you or your loved one answered yes to 2 or more, in fact, in some instances it would have been yes just to one of these, then you very likely have insulin resistance. And most people who have it are undiagnosed. It's manifesting as some other problem, like, say, hypertension. And then the individual and the healthcare practitioner simply isn't detecting the insulin resistance. It's not on their mind. It's not on their radar. Now, I'm speaking about this villain, which I contend is the most common health problem in the world, certainly in the U.S. and in many other countries too. We are not the worst. So what is it? Let's get to know this villain a little bit. And to really understand the villain, we need to look at insulin and its relationship to the cells of our body. So insulin will come to a specific receptor on the surface of a cell. It is a receptor that is built for insulin. It is, if you will, a door that only insulin can knock on. Once insulin comes to the cell and knocks on the door, something happens. Now, I'm just calling it action. There's something in the cell that happens, and we'll call it a cellular action. I have to be kind of vague in calling it action because insulin can do different things at every cell in the body. And I do mean every cell. Literally, every cell in the body has insulin receptors, and it will tell different cells to do different things. So insulin comes and knocks on the door, something happens. Now, over time, that something can be diminished. So the cell is resisting what insulin's trying to tell it to do. Now, that doesn't happen in all cells. Some cells of the body won't respond to the insulin the same way. And now watch, accordingly, what happens is that the body is making more insulin. And so what was once, when insulin would come to the cell, it would politely rap on the door and then something would happen. Now, in order to try to get the cell to do something, it needs to pound on the door. And in so doing, it can restore some of the function of insulin's signal at that cell. So throughout this brief introduction of insulin resistance, and I'm not doing it fully justice, and appreciate that, please. This is something that scientists, myself included, have been studying for decades. In my case, it's 15 years at this point. So there are two takeaways as you understand it, and as you're conveying this to people you're concerned with. You define insulin resistance in two simple ways. The first being that some cells of the body aren't responding to insulin the same way they were before. And then two, and this one is essential, there is more insulin than there was before. That is an essential feature of insulin resistance. If you take away the hyperinsulinemia, there is no insulin resistance. Now let's look at this as it would relate to glucose in a person as they are progressing through their lives. And you'll notice on that x-axis, I'm defining time in years. So this is something that's not, acute. This isn't happening after a meal. It's happening over time. And so over time, glucose is climbing as someone's progressing more and more towards poor metabolic health. And insulin, I'll rewind that, insulin takes that curve where it spikes up early over the progression of this metabolic disorder, and then it reaches its peak, and then it starts to descend. Now, importantly, it does not get as low as it was before. So if we break this up into two stages, this first stage that can happen, of course, for decades, that is insulin resistance, and it's also one that can start early in life as well. This state, which is so often missed, remember, it is overwhelmingly undiagnosed or misdiagnosed as some other problem. This is a state where insulin is elevated, but glucose is normal. And because we look at metabolic health through the lens of glucose so often, it continues to fly under the radar, like I mentioned earlier. We're always looking at the glucose, and so we miss the fact that there's this silent war being waged behind the scenes where insulin is elevated, and insulin is working harder and harder and harder to try to keep that glucose in check. But it is keeping it in check. And then eventually, as we progress over time, insulin starts to lose the war and glucose starts to climb, and then it is even amplified as insulin levels not always, may start to come down, but it will still always be higher, insulin that is, than it was before it ever started. So by the time we progress to type 2 diabetes, both insulin is elevated and the glucose. But remember, we've got to look at the insulin. And just one takeaway for you, because we've ignored insulin for so long, we've overlooked it, there is no broad consensus on what should be a cutoff for insulin, like we have, say, for glucose levels. My cutoff that you can take to the bank is 6 microunits per mil. And that's because of what we see across populations. People who eat indigenous diets that have no whiff of metabolic disorders, they have on average a fasting insulin of 4 microunits, whereas the average American has a fasting insulin of 9. And remember, in this case, it is not good to be average. Because the average American is metabolically unhealthy or unfit. So 6 microunits is, the gospel according to Ben Bikman when it comes to insulin. So that, the villain now. We've defined it, but how did it get there in the first place? So let's just take a few minutes to explore how the body develops insulin resistance. And it really is something that happens almost like dominoes falling as it starts spreading through the body. And please appreciate that I'm speculating a little, although it is, if I may say so, informed speculation. But we don't exactly know where insulin resistance starts. What is the one point, if it is indeed one point? But I'm going to submit one theory to you that I do believe is justified. Of course, otherwise I wouldn't be doing it. And that is that in most instances, insulin resistance is going to start at the fat cells. And I'll explore this with you more in just a few minutes. And then as the problem progresses, and I'm just showing 3 examples here where it would progress to type 2 diabetes. That's when the muscle and the liver and even the pancreas itself starts to suffer from that insulin resistance as well. And I will touch on some other tissues in a moment just to help you appreciate the scope of it. But for the sake of us defining and understanding the origins of insulin resistance, it's really helpful to start at the level of the adipose. And now as we look at causes, even including other tissues beyond adipose, there is substantial evidence to show that too much insulin itself, which is the term being hyperinsulinemia. Emia, anytime you hear that suffix emia, it means in the blood. So too much insulin in the blood. That is a known cause, and this is known very well to cause insulin resistance at both fat cells and muscle cells directly. And there are some references if you are skeptical or your friend is skeptical. Put your friend in his or her place. Stress itself is a known cause, and specifically the stress-related hormones like cortisol and epinephrine. Those are insulin antagonists. Now, I'm not saying those are bad hormones, just like I don't intend to ever say insulin is bad. They all play their own parts in this glorious orchestra of endocrinology within the body. But too much stress and the chronic presence of these stress-related insulin antagonistic hormones will drive insulin resistance. In fact, let me elaborate on that just for 1 second. When someone is taking anti-inflammatory drugs like cortisol-like drugs to control autoimmune inflammation, and these are things like prednisone or dexamethasone, that actually checks that same box. It's acting like cortisol, which does control inflammation, but it also antagonizes insulin. So there's a pretty heavy price to pay, and that's why those drugs should be used sparingly. And then lastly, oddly enough, inflammation itself can be a driver of insulin resistance. And just for the sake of time, I'm not going to get into that, although for now, but if you guys have questions, once I get done, by all means, drop some of those questions in the chat and I can address it. That's a topic that I'm quite familiar with. All right, so hyperinsulinemia, because I contend that it is the main one. It is the big one. It is the elephant in the room when it comes to driving insulin resistance. And that's really reflected, it is reflective of a fundamental biological principle. In the body, as insulin's climbing, insulin sensitivity is reducing. This, like I said, it's reflective of a biological principle where too much of something in the body will start to result in a resistance to that something. And we see this in human nature or human physiology. In order to continue to get, say, a fix or a buzz from some chemical that someone's taking in, an illicit drug or a more acceptable drug like caffeine, the body needs more and more of it to get that same response that it used to get just from a smaller amount. We see this also reflected in other hormones, not just insulin, but insulin is one of them that we should appreciate. So too much insulin can cause insulin resistance. In fact, this is something that has been explored in a laboratory setting where in these young, healthy, college-age males, just simply bumping up their insulin, even though it was still in a normal range, they became demonstrably insulin resistant within just a couple days. So when you hear people that are trying to throw some shade on the idea that insulin itself causes insulin resistance, it is frankly wrong. We can cause insulin resistance rapidly in people. So as much as people want to focus on other points, I wouldn't say other points aren't relevant. Indeed, I mentioned stress and inflammation, but insulin itself has to be considered as a part of this overall equation. Now let's focus a little bit more on the adipose tissue. And to understand its role in driving insulin resistance as sort of the first domino to fall, and then it's spilling its insulin resistance to other tissues, in a way kind of literally, it really is about size. Now, insulin loves to promote fat growth. And so when a tissue is getting fatter because of insulin exposure, or even in my laboratory, when we want to make fat cells get big, we have to include insulin into this little petri dish cell culture. Insulin helps promote fat tissue growth by fostering two effects. One is having a fat cell start making its own fat, so lipogenesis, storing more triglycerides. And then secondly, adipogenesis is when the fat cell starts proliferating. So in other words, we get more and more of them. Both of these come into play as someone is getting fatter. But which one of these predominates ends up determining whether the fat cells are sick or whether they are healthy. Now, to explain this another way, fat tissue can grow through either individual cells themselves growing or the cells multiplying. So when the fat cells themselves are growing, that is a hypertrophic fat growth, or in other words, hypertrophy. In contrast, what we have, an alternative method of fat growth, is through hyperplastic fat cells, or hyperplasia of the fat cells. That's when the cells are multiplying or proliferating. We have more of the cells. So in the hypertrophic case, the fat cells themselves, we have a finite number, but they're getting really big. Alternatively, in hyperplastic growth, the cells never get that big. They're still pretty normal dimensions, and yet rather than growing, they end up multiplying. So they have more fat cells, but they're all at pretty modest size. Now you can imagine at the level of the whole body, or the level of the fat tissue, that's still a belly that's getting bigger. It's just, how is it getting bigger? Through hypertrophic fat cells or hyperplastic fat cells? Because the former is bad, the latter, hyperplastic, is good. Now, you'd say, well, it's not good to get fat at all. I agree, it's not. But there is a healthy way to get fat, or some people can get fat and maintain a reasonably good health. Other people get even moderately chubby, and they start having pretty profound metabolic consequences. Now, here is another way of kind of defining it. If we go down one layer deeper, the hypertrophic fat cells are essentially too full. They're filled up. They lack sufficient blood flow. They become somewhat hypoxic, or they can't get enough oxygen to maintain normal cell function. They become inflammatory. They start leaking pro-inflammatory proteins called cytokines. And these cells are becoming, they're starting to resist insulin's effects, because insulin is trying to tell these fat cells to continue to grow, because insulin loves to tell fat cells to grow. But it's essentially like these fat cells have reached their limit. If they get any bigger, they're gonna explode. You know, I'm not literally, but you get what I'm saying. They've reached their maximum dimension, so they become resistant to insulin's effects. And in the process, they are leaking their fats, so they're leaking free fatty acids, and they are leaking these pro-inflammatory proteins, just almost as a call for help, because that's what cytokines do. Cytokines signal to the body that, hey, we need help in one particular area. In contrast, with hyperplastic fat growth, the fat cells are never getting to the point of dangerous. They're always healthy sized. They have perfectly good blood flow. They can continue just to store more and more fat. Insulin comes and tells them to store fat, and they keep doing it very gladly and happily. So they maintain insulin sensitivity, and the body, while getting fatter and fatter, is able to maintain reasonably good health. Now, in the case of the hypertrophic fat cells, and at the risk of getting a little too deep, but I won't go any further than this, but I know you're all a bunch of nerds, so you're going to appreciate it anyway. This combination of a lot of free fatty acids and these pro-inflammatory cytokines, that is the catalyst, or indeed the literal kind of signal and building blocks to create a different type of fat called ceramides. And as ceramides accumulate within cells, like, for example, some of the ones here, muscle, liver, and even brain, and far more, they are directly causing insulin resistance. Ceramides directly antagonize what insulin's trying to do. So insulin would come and knock on the door, then something would happen. Ceramides stop that something from happening. So ceramides are direct antagonists to the insulin signal or the cascade of events that happens in a cell. Now, here are three that I just mentioned: muscle, liver, and brain. And just to kind of help you guys appreciate some of the relevance of insulin resistance throughout the body, let's just briefly look at what happens. In the case of the muscle, when it becomes insulin resistant, it cannot protect its muscle proteins as well. Muscle, when insulin comes to the muscle, one of the reasons insulin is an abused hormone in bodybuilders, insulin helps defend muscle from breaking down its proteins. So if you don't have insulin working, the person starts to experience muscle loss. And this is likely some of the muscle loss that we see happening even in this situation nowadays called sarcopenic obesity, where the person is very overweight. They should be strong by moving those muscles around, by moving themselves around, because there's just so much mass. And yet that doesn't happen. The insulin resistance is making it harder for the muscles to maintain their mass. In the liver starts to increase its production of fat, so it gets fatty liver. It also releases more triglycerides into the blood. So if someone has high triglycerides, it is very often a result or an early symptom of hepatic or liver insulin resistance. At the brain, the insulin resistance is likely causing the very real, demonstrable reduction in brain glucose uptake. And very briefly, this would be a talk in and unto itself. The brain is an energy hog. It has a very high metabolic rate. And in the average person who's constantly eating, they're eating starchy, sugary meals every 2 to 3 hours, glucose is providing all that fuel. But and I say that just because they have no ketones, although I'm not going to talk about ketones other than mentioning it now, probably. But if what's happening is the brain has this much energy need, it's trying to meet that need with glucose. And once upon a time, it could do it. But as the brain is becoming insulin resistant, it can't get all of its energy from glucose alone. So there's an energetic deficit, a gap, that can only be filled by ketones. But again, the average person doesn't have any ketones because their insulin's spiked all the time. But again, I won't get into that. Quit distracting me. That's too much of a tangent. So the brain has this energetic gap. And that energetic gap is thought to be part of the problem in certain brain disorders like Alzheimer's disease, like migraine headaches, like epilepsy. And even mentioning migraines, that is an area of research that is over 100 years old by this point, where people suffering from frequent migraine attacks, they go into ketosis and they either drop down to a tenth of how frequently they were before, or they stop altogether. It is just a phenomenal reversal of the problem. All right, now let's go on. Gonads, and I could mention testes too, but it's just more profound at the ovaries. Too much insulin is actually blocking the ovaries' ability to make the proper cocktail of hormones that should predominate in a female body, which is, of course, as you know, relatively more estrogens than androgens. Although both sexes have both estrogens and androgens, of course, what you might not know is that all estrogens in male and female were once androgens that the gonads start to convert into estrogens. If there's too much insulin, it stops that conversion. So we look at fertility in a woman, which is a very complicated situation. I just mean, speaking of just the hormones themselves, it is this really incredible orchestra of hormones ebbing and flowing throughout the month to facilitate the normal menstrual process. Part of that process prior to ovulation is that there has to be this big spike in estrogens, but too much insulin is blocking that, and we don't get that spike in estrogens. We just have too much androgens going through the body, and that is the fundamental problem with polycystic ovarian syndrome, the most common female infertility. And lastly, but again, I could go on and on, blood vessels. When blood vessels become insulin resistant, they cannot dilate. They're chronically constricted, and that is increasing blood pressure, as of course the lumen of the blood vessel is narrower, but it's also compromising blood flow, like in the instance of erectile dysfunction, something I believe Vinny knows a great deal about. All right, so how can we lower insulin? So I've defined to you that we now have a common understanding of what is insulin resistance and where did it come from. So who is the villain? What is its origin story? And now it's what can we do about it? How can we beat it back? The key here is just to lower insulin. And there are three ways to do it: drugs, diet, and exercise. And of course, diet's the big one, and that's the one I'll finish with. But very, very briefly, and this, once again, is kind of the gospel according to Ben. This is my definition of drugs. If I'm talking to a loved one and they're worried about this and they're kind of running drugs by me that their physician has mentioned, I do weigh in, of course. I can't help it. I'm too opinionated not to. And even still, so here are some good ones. Metformin and something like aspirin. They work and they have fewer side effects than most, but every drug has a side effect, every drug, and it can only ever treat the symptoms. In the case of metabolic health, it will never solve the problem. Now, metformin is the most widely prescribed anti-diabetic drug in the world, and rightly so. It works reasonably well at improving insulin sensitivity directly, but there are side effects that someone has to be aware of. But even still, as effective as metformin is, lifestyle, and there's the reference if you don't believe me, lifestyle is twice as effective. And I would argue that if someone is doing lifestyle the right way, like I'll mention in a moment, it's going to even be more than that. So as effective as these drugs are, and me giving them a better grade, a passing grade, I would still say they pale in comparison when we look at lifestyle changes. And then the not so good drugs, let me just mention this briefly. Here is this thiazolidinediones. That's quite a mouthful, isn't it? TZDs. You actually understand how TZDs act because I defined to you the differences between hypertrophic fat cells and hyperplastic fat cells. So what TZDs do, it is a drug that will come to the hypertrophic fat cell and tell it to multiply. So what you're doing is taking hypertrophic fat cells and convincing them to become hyperplastic, so they multiply fat cells. And you can imagine two things happen. One, the insulin resistance does get better because now the fat cells can start responding to the insulin again. They can start pulling in more glucose and lipids and getting fatter and fatter. But that's the other side of the coin. This paradox where the person's insulin resistance is getting better, but you're doing it because you're pushing their fat cells to grow, well, to proliferate, to multiply. And so they're getting fatter, and yet their insulin resistance is getting better. Indeed, the patient getting so fat so quickly is the main reason why adherence to TZDs is so terrible. The person's looking at the 30 pounds they gained in 6 months and thinks, I'm not taking this crap anymore. And you can't blame them. Now, here, mentioning the other two, sulfonylureas and insulin, these work, of course, they're used because of the glucose-centric paradigm that we have to look at insulin resistance and metabolic health by extension. We look at it as a glucose problem. And so the average clinician is thinking, well, I don't care what insulin does. So they will look at this situation of high glucose, although probably have very little idea on average of what insulin levels actually are. But they will think, let's just push the insulin up even higher because who cares about insulin? That's not relevant. The shame, of course, that's terribly wrong. But they'll say, well, let's just push insulin up even higher, and that'll help lower the glucose. And it does lower the glucose. But unfortunately, as absolute evidence that glucose shouldn't be the main marker here, when we start treating people with these class of drugs, we know, it is documented, and I regret that I didn't put the PubMed IDs here. I'm free to look it up. I'm sorry about that. There is an increased risk of cancer, increased risk of cardiovascular disease, and an increased risk of Alzheimer's disease. Those are not good things. So we claim that we're helping them out, although it will never cure the disease. All we're doing is making them fatter and sicker, unfortunately. Now, exercise, I know that if you guys are following Vinny, you're acolytes of Vinny, you, of course, appreciate exercise as much as I do. And so what is the best one to do? And here is my very rigorous, scientifically validated conclusion. It is the one you'll do. So if you were talking to someone and they said, oh, well, you need to do CrossFit because that's the best, or you need to cross-country ski because minute for minute it's, the most rigorous. Yeah, that's great. But tell that to some overweight person who lives in Arizona, where they're not going to cross-country ski and they'll laugh in your face. So really, and I do mean it, the evidence supports this. Just do something. Just start with something and then just progress however well you can. All right, now diet. Let's briefly go in my waning moments here. Let's go through these things. So intermittent fasting, here's just one brief study, because intermittent fasting is really kind of coming into its own now, really thanks largely to the work of Jason Fung, and we ought to credit him for this explosion in interest in intermittent fasting. He published this case study that found that they were able to get type 2 diabetics off their insulin entirely in just a matter of weeks. So intermittent fasting works extremely well. To be fair, I need to mention that there is evidence to support the efficacy of a low-fat or low-calorie diet. But the evidence is it is mixed. But I will say very readily, if you start to starve someone through low-calorie, it will improve insulin sensitivity, especially as they start to leave from the standard American diet. It doesn't take a lot. If you start taking some steps away from the processed food of a standard American diet, you're absolutely going to start to get improvements. And then in a low carbohydrate diet, let me just present my paradigm with it and how I came to embrace it as an academic who once upon a time I was very opposed to. Once I appreciated the necessity of controlling insulin, I appreciated a low-carb diet more. Fat itself at normal levels, and I mean anything below like 500 calories, has no effect on insulin. There's a little bit of evidence to show that if you're going even higher, like 600-700 calories of fat, then there might be an insulin effect, although it is still modest compared to the other two. Protein does have an effect. Part of that depends on the glucose that someone is eating. But even still, it has an effect, and we need to acknowledge it. Then carbohydrates, the one macronutrient that is absolutely not essential to humans, and tragically is the one that is the base of most diets these days, the one thing that is non-essential, also happens to be the one that spikes insulin the most. But in all fairness, the type of carbohydrate matters, of course. Now, what happens when you compare the two of these? And this was part of my journey, again, as an academic, in appreciating the efficacy of a low-carbohydrate diet. I am mentioning studies, so the data that I'm showing you come from the studies that I'm citing in the corner here. Comparing low-fat versus low-carbohydrate diets. In this study, they found that glucose was an insignificant change on low-fat, but it was a significant 15% reduction on the low-carbohydrate diet. The results were more dramatic, even. Insulin dropped by 16% on the low-fat diet, and low-fat, low-calorie, and then on the low-carb diet, it dropped by 50%, and then a marker of insulin resistance had reflected similar differences, where in the low-carb diet, it was about a 56% reduction in this marker of insulin resistance. This study put people on 3 different diets, and you can see them defined here. I don't want to elaborate too much. You can read them as I go through the study. Well, in fact, there's not much to say, actually. In each case, the low-fat diet was the absolute worst performer. And there was more than just this. Looking at body weight changes, changes in inflammation, the low-fat diet was the worst, literally in every single metric. And can you just appreciate for 1 second how ridiculous it is that that is the standard protocol? That is the standard response in the conversation of how can I get leaner and healthier, low-fat. Now, there's a better way. And in this study, it suggests, as many others do, low carb is the better way. Another study, these kinds of changes, glucose didn't change much, although it was already pretty normal. That 86 was where it was already. So it didn't change too much. It was not significant. Insulin, they were measuring this in picomoles, although before I showed you the number in microunits, and I prefer those units, but this study used picomoles. The insulin climbed up a little bit in the low-fat group. It dropped a little bit in the low-carb group. And then insulin resistance, it started at around 1.28, this marker of insulin resistance called the HOMA, H-O-M-A. It went up, so it got worse, and it got better on the low-carb diet. And then one last study. This broke people up into 2 groups, the insulin-resistant groups and the insulin-sensitive group. And look at their insulin in microunits. By measuring insulin resistance, the fasting insulin in the insulin-resistant group was about 16 microunits. And you'll note that is above what is my cutoff, the 6 microunits. The insulin-sensitive group was at 5 microunits, which, as you'll recall, and I just reminded you, is below the 6 that I consider a cutoff. When they put both of these groups on a low-fat diet, there was an insignificant change. We're talking tenths of a point here with microunits. It was an insignificant difference in both the insulin-resistant group and the insulin-sensitive group. Now, when we looked at them in a low-carbohydrate diet, on the insulin-sensitive people, there was no significant change. This is important because some people might not have the same magnitude or even the same necessity to adopt a low-carbohydrate diet for good health. And if they are already insulin sensitive, then it suggests they're going to be fine on either diet. However, the difference is really noticeable in the insulin-resistant group. Once again, the low-fat group had no significant change, when they were on a low-fat diet. And then when the insulin-resistant group was on a low-carb diet, you can see that was a significant reduction in fasting insulin. So the efficacy of a low-carb diet is really contingent on a person's underlying insulin sensitivity. All right, now what might this look like? As I finish up, and because I'm not your physician, I can give you a little bit of advice without any fear of recrimination or litigation, because I'm just a scientist, and no one listens to scientists. Here are 4 pillars. Control carbohydrates, prioritize protein, fill calories, fill remaining caloric needs with fat, and then watch the clock. And what do I mean by this? Briefly, scrutinize the type of carbohydrate. Be smart about the starches you're eating, and then recognize sugar in all of its many forms and just how abundant it is in processed foods. Of course, the more processed the food, the worse it's going to be. So it behooves us to focus on fruits. Within reason, tropical fruits like pineapples, mangoes, you got to be careful with. Never drink fruits, just eat them. And then vegetables are generally okay, especially if they grow above the ground. Now, protein and fat, I bring these together because in nature, they come together. The best proteins, how am I doing on time? Oof, I'm getting close. The best proteins are animal source proteins, but without any debate. No debate. I won't get into that now, but it is beyond debate. And these animal source proteins like whey and beef and egg, they come with fat, and that's the way we should look at them. And so what kind of fat? I would say any fat except refined seed oils. And just to emphasize this, soybean oil has become the single most common source of fat in the Western diet. It is fat source number 1 because it is just in every processed food. And there are different ways to intermittent fast, whether it's within a 24-hour period like an 18-6 or alternate day or weekends. There's lots of ways to do it. I would argue that all of them have some benefit. So in conclusion, you guys, I hope that you understand this villain now better than you did before, and then appreciating, as I remind you, just how relevant it is to so many chronic diseases. Indeed, all the diseases we're worried about, rather than addressing them, rather than cutting off or trying to prune each branch and hoping that we've addressed the problem, let's just go right to the root of the problem and just cut down the whole tree, this whole metabolic disaster. All right, you guys, thanks for listening. I hope you've learned some things. I'm happy to answer some questions. In fact, I'm going to go back to that screen and I will, hold on, I'm going to try to get this to work. Okay.
Okay, I'm back. Can you
Andy,
hear me?
It looks like
Can you
I
hear
still
me,
can't hear
Ben?
you, Andy, you son of a gun. It's
Okay.
as quiet as ever, but I'm going to just start answering some questions here on the side until you tell me to shut up. Thumbs up. Andy, does that sound good?
Yes.
Okay. All right, beauty. All right, guys, come on, bring in some questions. I'm seeing all these things. Wayne just was saying, what was that? Soy effing Monsanto. Not love it, Wayne. Excellent. Stephanie, thanks. Robert, I appreciate it. All right. Okay. So David, thanks for the question. Are those the same cytokines you hear about when they talk about cytokine storm in COVID-19 patients? What an awesome question. I'm so glad you asked that. Yeah, it is. So cytokines are part of a family of both pro and anti-inflammatory hormones or proteins. What is so interesting in COVID-19 is that at least in I don't remember the number. I think it's about 30% of all deaths from COVID-19 are happening because people are having blood clots. They basically are stroking to death. And part of that problem is when I'd mentioned that how obesity is pre-existing condition number 1, It's because fat cells actually are among the highest expressors of ACE2, ACE2. That is the way that the COVID-19 virus gets into the fat cell to infect it. And then fat cells, once infected, create a cytokine called PAI1. And PAI1 inhibits the breakdown of clots. But anyway, I've gotten a little bit off topic. But yeah, the question, are these the same cytokines? Yeah, they are. And they are, without a doubt, relevant to COVID-19 lethality. All right. What else? So a guy named Ben. Ben, thanks. You said I don't drink fruits. Yeah. Honestly, don't. Even blended, I do not. I do not believe any form of drinking fruit is something that we should do. Admittedly, blended is better just because it's kept some of the fiber and it likely has less fructose. But you think about fruit juice, which is just pure fructose. That is just terrible to be loading the liver with. So you get a little less of that fructose when you've blended it, and you get a little more of the fiber. But even still, I'd say eat fruit the way God intended, and that is with your teeth. So that might not be, you might not want to hear that, but it's certainly the way I would look at things. All right, insulin testing, Leandro Pucci, insulin testing. Which one do you recommend? If you can just get your insulin measured at all, like next time you go in for a blood test, if you can get your fasting glucose and your fasting insulin, you can use that to create something. In fact, Dwight, you're asking what's the ideal HOMA IR. That sort of segues nicely. If you have your fasting glucose and your fasting insulin, you can measure your HOMA IR. And by all means, just look it up online. I believe it's insulin in microunits per mil times glucose in milligrams per deciliter divided by 405. And you want that number to be 1.5 or lower. Okay, so you want that to be less than 1.5, and then you're laughing, as we say up in Alberta. All right, skin tags. Can skin tags go away and get better? Absolutely, they can. So can the dark sections, which is something called acanthosis nigricans. That was Gene's question. So yeah, skin tags, the skin disorders, these skin signs, rather, of insulin resistance absolutely are reversible. As the insulin resistance gets better, so too do these manifestations of poor skin or manifestations on the skin. What are the best, Rick is saying, what are the best vegetables to eat? The least toxic? I don't want to get into toxins per se, just because that's something I'm not too familiar with. But I will say, let me go off. Let me riff for one sec. Because until Andy either flips me the bird or gives me a thumbs down. But plant proteins have become so prevalent. And you guys should know, from the side of the manufacturer, it makes all the sense in the world to use plant proteins because they are cheap. And I say that with experience. In fact, here's the shake. My brothers and I, when we started making this low-carb kind of fatty protein shake, my brothers said, well, let's look at pea protein. No. Every plant protein has anti-nutrients in them, and that sounds like it's the stuff of myth. It is not. Look up things called tannins or trypsin inhibitors or phytic acids that are prevalent in every plant protein. There are actual compounds that work their way, not to mention heavy metals like lead and arsenic, into these concentrated plant proteins that actually prevent your body from using them. So what are the best plants to eat with regards to metabolic health? The vegetables, really, if it grows above the ground, it's one that I give a green light to and enjoy frequently, frankly. Okay, another question. Carrie, I mentioned 6 being a good measurement. Do I have any idea what that would translate to type 1 diabetics injecting insulin? Oh, that is such an awesome question, Carrie. I wish I knew. I'm sorry. I don't know. I admittedly am a type 2 kind of guy. That's what I focus on. And then type 1 is a different beast entirely. And I don't know what that would look like with regards to units per day. But I will say that there are studies to show that when even type 1 diabetics adopt a low-carb diet, their time in normal glycemia is significantly higher. They basically avoid all those excursions. outside of normal. Ed Bailey, what are you saying here? That's a little long. Sorry. 1 pound of meat will bring your glucose down. Eating the same amount of fat, the glucose won't go as high. I think that's what you're saying. Gluconeogenesis is demand-driven. I'm curious what the addition of fat is having. Yeah, I don't know. I'm sorry. I wish I knew, and I'd have to think a little bit more to answer that one. So I'm sorry for kind of passing that one over. Okay. So in fact, you guys, hey, listen, thanks so much. I appreciate the time. Andy, thanks for arranging all this. Vinny, if you can hear me, thanks again, brother, for the invitation. It's always a pleasure. Guys, I hope you all learned a lot, and I'll pass the mic back to Andy.